Hello everyone, and thank you for joining me today. The world of restorative dentistry has undergone tremendous advancements over the last 10 years. While this has been a net positive for our profession, in many ways, dentistry has become more confusing. Today we have numerous ceramic materials and many different types of cement. My name is Parag Kachalia, and over the next hour, my goal is to help clear up some of this confusion that surrounds our new materials. In addition, if you have an Instagram account, you're welcome to follow me at TechDDS, as I tend to post new materials, technologies, and techniques that are changing dentistry. Disclosures are always important, and it is important to know that GC America is sponsoring this webinar today, and that they have provided honorary support to me. While GC products will be shown during the presentation, the core of the presentation will focus on understanding the best practices of materials today, and my goal will be to not make this a sales pitch in any way. In our time together, we have 4 key objectives. There are 4 basic objectives in this presentation I want to cover. The first is to gain an understanding of the advances in ceramic dentistry over the last 5 years. Next, we'll look at preparation design as it relates to new ceramics in the marketplace. We'll follow that by looking at the pros and cons of these various ceramic systems and as they relate to clinical decision making. And finally, we'll discuss cementation techniques specific to each ceramic system. Just because we have restorations that look similar and that they're both tooth-colored restorations, the way we cement a zirconia restoration today may be very different than how we bond in a glass ceramic. So we'll discuss some of those nuances and the differences between them. Now, the world has most definitely changed. It was not that long ago that a porcelain fused to metal restoration was a primary restoration of choice in the United States. Interesting enough, about 7 to 8 months ago, Glidewell Dental Laboratories announced they would no longer fabricate traditional PFM restorations. Now, Glidewell is one of the biggest laboratories in the United States, and they've moved away from traditional processes of porcelain fused to metal restorations. So this tells us the world is definitely changing. If we take a look at some of this data, the change in material usage has been occurring since the 2007-2008 time period. In 2007, PFM usage was greater than 65%. Today, we're at less than 10%. This shift has gone towards all ceramic restorations, and this shift has happened for multiple factors. One of the primary factors has been the decrease in cost with these newer ceramic materials that are out there. If we think about the 08-09 time frame, gold prices shot up, and around that time, new zirconia restorations as well as new glass ceramic restorations started to hit the marketplace, and clinicians saw very positive results. In today's presentation, we're going to discuss the two most popular types of ceramic restorations. These are lithium disilicate and zirconia restorations. Lithium disilicate restorations are glass-based and historically exhibit strengths of approximately 360 megapascals. Zirconia restorations do not have any glass, and they have a flexural strength of around 800 to 1200 megapascals. In the newest area of dentistry, we're starting to gain more traction to this world of what we call translucent zirconias. So historically, it was this lithium disilicate area, as well as zirconia, and that's really been the last 10 or so years where these materials have really kind of taken precedence. And today, we're starting to see things like Inceram and alumina go away. We don't really do many of those restorations today, and instead the world of translucent zirconias are starting to become more prevalent. And these translucent zirconias have a flexural strength of about 600 to 800 megapascals. Now, if we take a look at the lithium disilicate area, that's been the historic standpoint that's there. That area of the marketplace is seeing tremendous evolution. The typical name we know in there is Emax, and Emax has done a phenomenal job. But as time has gone on, more and more manufacturers are starting to look at the nuances of this type of material and to say, how can we make these types of restorations even more beautiful and potentially have equivalent, if not greater, strength? So what we're starting to see is this generation of what we call the lithium disilicate as well as lithium silicate world. In that world, we're starting to see flexural strengths of 4 to 500 megapascals. So this world of dentistry is really kind of three parts today. The world of dentistry is a glass ceramic in the 4 to 500 megapascal range, and that's usually your lithium disilicate or lithium silicate world. This evolution of translucent zirconias, and then our traditional zirconias, which tend to be more opacious. So each one of these are really throughout dentistry today, but the way we cement these restorations may have some differences, depending about how thick they are, whether partial coverage or full coverage. There's different nuances that can really leverage the properties of these materials to get long-term benefits for the patient. In this new world of ceramics, we have tremendous choice. And new materials today are substantially stronger than the feldspathic porcelains historically. Yet their aesthetic potential is not that different. One of the biggest benefits in new age ceramics is that we in fact may need to have less tooth reduction and yet have higher strength. If we look at the traditional feldspathic restorations done on the left-hand side, those veneers had a flexural strength of about 80 megapascals. Today we have lithium silicates and disilicates that are in the 4 to 500 megapascal range when proper adhesive bonding occurs. So suddenly we have 6 to 7 times the strength, and we really haven't sacrificed much on the beauty end. At the same time, the newer restorations may be more predictable. So the good thing today is we have choice. In these clinical slides, you can see a full zirconia preparation on the upper left second molar, adjacent to lithium disilicate onlay preparation. A healthy band of enamel is maintained circumferentially on the onlay to optimize the bond. However, in areas where deep dentin is, a little more reduction is done. We see 1.5 to 2 millimeters of reduction in order to achieve the right amount of clearance in the central fossa, as well as the mesobox forms, if not greater. However, in areas where there's pure enamel, I can be more conservative. In these pure enamel areas on this upper left first molar, in those areas, I may only need 1 millimeter of occlusal clearance. And that 1 millimeter may allow enough strength in the material when it's adhesively bonded. At the same time, with the second molar, we're doing more of a traditional zirconia preparation. We have an existing restoration to start with. We remove that. Much of the axial and occlusal preparation was already done. This area of the mouth is going to take some more force. So we chose a zirconia restoration in the second molar. However, in the first molar, we did a lithium disilicate restoration in this case. So with the disilicate restoration, we bonded it. And with the zirconia restoration, we conventionally cemented it. But you can see two materials side by side, one in a partial coverage form, one in a full coverage form, both blending into the dentition and both having the appropriate cementation protocols. And we'll discuss these nuances as time goes on. The area of dentistry is continuing to grow. The product we all know in terms of brand name has been Emax by Avocar. And while this is a great material and other similar materials are coming into the marketplace, the general indication of these materials has been single unit partial coverage restorations, single unit full coverage restorations, and selective 3-unit bridges, as well as things like veneers. Now, the most terminal tooth should really not exceed a second bicuspid in terms of 3-unit fixed partial dentures or bridges. So material can be used for multiple splinted units as long as we limit those units to 3 and max. At the same time, we really try not to go past the second bicuspid. When we go past these areas, especially in a bridge standpoint, what we tend to find is fractures occurring at the distal connector. But the beauty of this category of materials is that they're fantastic for partial coverage, as well as full coverage restorations, and selective 3-unit bridges, especially in the aesthetic zone. We can really start to optimize the physical as well as the cosmetic properties. A material most of us have used with great success now has been Emax. And historically, this material demonstrated a flexural strength of about 360 megapascals. In the milled state, it was claimed to have 400 megapascals. Excuse me. In the flexural strength, the milled state was 360, In the press stage, it was 400. Now, those numbers are really irrespective of cementation technique. They're really just kind of material properties. Today, multiple reports are available, so multiple third-party studies are available, where we suddenly see flexural strain approaching 500 megapascals as long as the restoration has been bonded. And this bonded aspect we'll look at in more detail. Now here's a case that I did with Emacs about 5 years ago. After putting the patient into clear line of therapy first, in order to have an orthodontic movement occur, get the teeth in a better position, a series of veneers and some selective full coverage restorations were completed. Now the patient was very happy with the end result. However, as clinicians, we always need to move forward with our care and understand, can we do something better? Can our dentistry improve or have materials improve, or the combination of both? And if we critically look at these restorations, they lack some depth and color. Now over time, new ceramics or new opacities have come about, but at this point, about 5 or 6 years ago, these restorations were reasonable, but didn't quite have the depth and color that I wanted, and they appeared a little bit opacious. If we look today, we'll start to get into this new world. We start to get into this new world where, over the last year or so, a material called lithium silicate, specifically LisiPress by GC, has come to the market. Other manufacturers also have lithium silicates. And with this material, with the GC's LisiPress in particular, we start to see a lot more depth and color, some beautiful translucency that can be achieved, and just more of a lifelike look to these restorations. They're simply amazing. Now, why can we accomplish this? So what GC has done with their LisiPress product in particular is they've really looked at the fill and taking a look at how are the microcrystals actually filled in the product. We want to create a material that's kind to the opposing dentition, but create a lifelike aesthetics. In order to create a life aesthetics, we have to change the particle size to some degree and get a denser fill. So we start to look at the two SEMs. The top one is GC's initial LisiPress, and the bottom is that of Emacs. You can see the density that's different. And that density difference seems to make a tremendous difference in terms of the richness and warmness of color. We start to see a really beautiful fluorescence that starts to come about as well. So it's almost similar in strength to that of an Emacs, but the coloration starts to look different. We start to get more depth of color and a real lifelike look. So here's a recent 6-unit case that we did at our practice. This patient was unhappy with the upper 4 anterior teeth. She felt as though her upper 4 anterior teeth didn't have nice contour shape size, concerned with the color that was there, had some chipping that was present, and decided that she wanted to undergo some cosmetic treatment, increase length a little bit, get some more translucency. So in this case, we decided to use LisiPress. And LisiPress was provided for the upper 4 lateral to lateral incisors, so lateral, central, central, lateral, as well as the lower 2 central incisors. And if you look at these little nuances, we start to see some crazed lines and things that are there. And we start to get to the point where we start to see more depth and color that are not too opaque. We see translucency, we see texture that's present. And this is all in combination with the beautiful work that our ceramists did over at Synergy Ceramics in conjunction with the types of materials that are available today. There's really a harmony that's occurring between the clinical dentistry as well as the laboratory work. So nice preparations followed by proper laboratory technician skill set to be able to pull these restorations off. And in the end, this patient was very pleased because they felt like they had a really nice, warm look to them. In another case, we start to look at the characterization possibilities. So this is another case by MJ at Synergy Ceramics on one of our patients. And the characterization here is truly phenomenal. With this material, she was able to get to a point where she builds in these crack lines, this coloration, the translucency, the incisal halos. All these things become possible. And we look at this patient, in this case on the master cast, and we transition into the patient's mouth, you can see how these restorations start to blend in place. This gentleman presented to our office, and he had concerns about his central incisors. His concern in particular was that the upper right central incisor as well as looked a little too rotated, as well as there's too much brown stain on it. The upper left central incisor had an old direct bonded restoration, which he was no longer happy with the aesthetics of that. At the same time, he wanted things to look natural in his mouth. He did not want to have 6, 8, 10, 12 veneers done, but rather wanted something that can blend into a smile. So while this material can be used for full mouth rehabilitation, it can also be used for a single central incisor, in this case, 2. So MJ was able to create these restorations that started to really build in and have beauty within his mouth. And he was incredibly happy that he did not have fake-looking teeth. Rather, he had a set of restorations that looked very natural. Now, in our most recent case, and this was just delivered a few weeks ago, we had this gentleman come to the office, and he had really a concern with his upper left central incisor. He had 2 teeth with drastically different stump colors, with the darkness of the upper left central, a little more opacity on the upper right central. 2 veneers are planned in this case, and we wanted these to blend back into the dentition. So we had 2 different stump colors, yet the final result, that's completely hidden. So teeth with 2 different kind of dentin shades or stump shades that were there. Our talented technician again used Lissy Press to accomplish 2 central incisor restorations, and these photos were taken immediately after cementation. So the adjacent teeth are slightly dehydrated. Because the adjacent teeth are slightly dehydrated, they're a little bit more kind of a whitish opaqueness to them, but the central incisors still match really well. We did not have a chance to take a post-op photo, a week or so later, but we can see that the color is blending in very, very naturally, very authentically, and these restorations have depth to them. And that's what's been so phenomenal about this material. Now, a benefit, in addition to that, is part of the reason these look so nice in the mouth of this new material, is I believe is because of the natural opalescence that's available, as well as the fluorescence. So we look at the natural opalescence that's there, it looks very similar to natural tooth structure. In addition, the fluorescence that's there, the fluorescence is very similar to how our natural teeth fluoresce. So we don't have that kind of dead look that's there, the traditional look where we know this patient's had a restoration done. There's so much more natural aesthetics that are present with these new materials and the optical properties. And it's been a material we've been quite happy with. To date, the vast majority of our work has been the anterior portion of the mouth. However, we are starting to venture into posterior aspects as well, in particular partial coverage restorations with onlays. Now, the lithium silicate world is not the only new kind of world of ceramics that are out there. There's others available as well. But there's a lot of intriguing things that are happening in this world. If we start to look at zirconia, zirconia has been frequently used over the last 5 to 10 years. Many, many offices globally are treating patients with material. And it's essentially become our go-to material of choice today for full coverage restorations on second molars. And in some cases, we use it on first molars. Essentially, our first molars today, and maybe the second bicuspid, has become our transition zone. When a patient has high occlusal load, we tend to place zirconia restorations. With lower occlusal load, we may consider one of the translucent zirconias that are available today, as well as potentially a glass-based ceramic. So with the translucent zirconias available in the marketplace, these have only been around for a few years. And we're starting to see this category grow. For the most part, our posterior, our second molar restorations historically, have been a slightly more opacious yet stronger translucent zirconias. In the bicuspid region, we are starting to use more of the translucent zirconias today. And in selective anterior cases where there's been substantial wear, both powderly as well as facially, or cementation techniques can be more complicated. In those cases, we also use zirconia. Zirconia has been a very popular material in dentistry because of the fact, historically, it has some self-healing properties. So the thought process with the zirconia is that if a fracture starts, you may be able to fuse the fracture. The material may be able to do that. Now, the key to self-healing is a tetragonal stage of zirconia. So this is the stage it starts in. This tetragonal stage, when a stress is applied, shifts into what we call a monoclinic phase. And as that shift occurs, there's about a 3% volumetric increase that happens. And when that 3% volume increase happens, that gets us to the ability to potentially fuse cracks. Now, we never want this change to occur, so in theory, this change should never happen. But if a stress is applied, this change can happen, and that change may help us save a fracture from propagating. And that's why one of the big reasons zirconia has been so popular. And it comes from the NASA program as well as high-performance German cars, etc. Zirconia is a very popular material in this case. We've been able to adapt it to dentistry. In dentistry, we've historically used what we call yttrium-stabilized tetragonal zirconia. However, today we're moving towards the more cubic zirconia world. In the cubic zirconia world, cubic zirconia adds clarity to restoration. However, to add clarity, there is a downside. As the clarity is increased and as the cubic zirconia concentrations increase, there is a loss of strength. So in order to get clarity and beauty, we have to decrease the amount of tetragonal zirconia that's available. In turn, that lessens the strength for it, but we tend to get beauty out of it. So it's not just arbitrarily we can go ahead and do this and that's a great benefit and all the strength is still there. We are sacrificing strength, and we must be cognizant of it. One of the big benefits of cubic zirconia is this light transmission. So we go from the tetragonal phase into this monoclinic phase, light transmission occurs appropriately. Because this cubic phase is present, the distance to any portion is the same. By being a cube, it's the same in all dimensions. Light's able to transmit through something that's the same in all dimensions, more so. That's what leads to translucency. In the tetragonal phase, on the other hand, it's more asymmetric. We have one side that's longer compared to the other side that may be shorter. So in these cases, light gets bent more. We don't get the same translucency. In order to get translucency, we must have that cubic phase. If we think about traditional high-strength monolithic restorations, the aesthetics have increased. So we take a look at these photos, the photo here. The second molar has a monolithic zirconia restoration. There's no veneering ceramic on top. On the other hand, the first molar has a veneered zirconia restoration. And in this case, this particular case was done with lava plus on the second molar and then lava veneered on the first molar. Now, if we compare the strength between those two, they're drastically different. The second molar is upwards of 1,000 megapascals of flexural strength. However, the first molar, that veneering ceramic can fracture off. That's much, much lower. That's like a feldspathic porcelain. If we compare the aesthetic properties between these two, there's really not that much of a difference. They're very, very similar. They're almost identical in nature. So from that standpoint, we have some clear benefits that are available to us. We can go monolithic and not have to worry about chipping, and yet get very similar aesthetic results today. Now, if you take a look at the scenario today and what we should consider, where we should consider using translucent zirconias, in the posterior, so in the posterior, really first and second molars today in non-aesthetic cases, so 100% of the time the second molar is really a non-aesthetic area. The first molar, at least 70% of the time, would be non-aesthetic. I'm still using our traditional zirconias. Those traditional zirconias have about 80% tetragonal form and about 30% cubic form, allowing light transmission. On the other hand, as I move anteriorly in the bicuspid zone, all the way up to central incisors, if I'm going to use a zirconia today, I would consider using a translucent zirconia. I'm going to give it some strength here, but I know my occlusal load is also less in these areas. So translucent zirconias today have about 50% cubic zirconia, and that's what allows a light transmission, and about 50% tetragonal. That's where that increase has occurred. So let's take a look at how these restorations can look in the mouth, especially in conjunction with how they look next to a lithium silicate or disilicate restoration. Now in this case, a patient had a conventionally cemented full crown on the upper first molar, on the upper second bicuspid. And the upper second bicuspid was a translucent zirconia. On the upper first bicuspid, on the other hand, was a lithium disilicate restoration. Now, we take a look at these two scenarios. The second bicuspid will have about 800 megapascals of flexural strength, and the first bicuspid will have about 500 megapascals of flexural strength. The aesthetics are slightly different between the two. The coloration may also be off, but they're well within the ballpark of reasonable. This patient's perfectly happy. Zirconia also photographs a little bit differently because the overall light transmission is different compared to glass-based ceramics. So in one case, we were able to cement. So in zirconia's case, we were able to use a self-adhesive resin, a very simple cementation process. On the other hand, in the upper first bicuspid case, we did a bonded lithium disilicate restoration. And the reason we bonded it is because we know when we bond, we increase our total strength. Bonding is very, very important. And this bonding aspect kind of transitions into how we prepare teeth today. Because of the beautiful cements we have, if we're willing to take the standpoint of bonding and restoration and utilizing cement and adhesive, we may be able to be more conservative in our dentistry. In this day and age, our patients are living a lot longer, and we must think about preserving as much tooth structure as we can. An individual today that is 60 years old in the United States has a life expectancy of about 83. So if they're 60 years old today, they'll live till about 83 years old. Now imagine somebody comes into your office at age 25. And when they come into your office at age 25, they present with a broken cusp. If they present with a broken cusp today, in many practices, that patient will receive a full coverage crown. And that's a reasonable treatment philosophy. On the other hand, if we look at they're 25, they're going to live until 85 years old. They have 60 years. They have 60 years where this restoration may need to be replaced at multiple standpoints. Roughly every 10 or so years, that restoration may need to be replaced. But what if we're able to preserve a lot more tooth structure? That could be a tremendous benefit to that patient. We may not need to lead them down the road of getting a full crown. Now, something that really changed my philosophy in regards to full coverage versus partial coverage restorations, and just material properties in general, was this statistic in this chart by Dr. Schillingberg out of the textbook Fundamentals of Fixed Prosthodontics. And what Dr. Schillingberg and his team did is they essentially did a retrospective study. They looked at restorations that were placed in full mouth x-rays in roughly 1966, and looked at all the restorations that were placed in a full coverage standpoint or indirect standpoint. So anything that had an onlay, a full coverage crown. In those two cases, they compared whenever a full coverage crown or onlay was done, what was the incidence of periapical radiolucencies or non-vital teeth. They did the same thing in the 70s. They looked at all the full mouth series of x-rays in the 70s, and they saw an increase, threefold. So a threefold increase in the number of teeth that needed to have root canal therapy or had a periapical radiolucency. In the 80s, it increased even further. And along this time, what occurred is materials changed. In the 1966 time period, when the first set of full mouth x-rays were reviewed, really those full coverage gold crowns were being done. In the 70s, porcelain-infused metal restorations came about. In the 80s, porcelain-infused metal restorations, as well as the early all-ceramic restorations came about. And with this came greater preparation criteria. More axial tooth reduction needed to be done, as well as more occlusal reduction. And the question we have to ask ourselves is, well, is there potentially greater periapical pathology because of preparation design change? If we take away more tooth structure, are we potentially leading to pulpal necrosis or pulpal death? And that's something we must be cognizant about. So today I would argue that porcelain-infused metal restorations may be the most aggressive preparations that we do. These preparations require 1.3 to 1.5 millimeters of reduction in order to be ready for a nice restoration to be fabricated. So 1.3 to 1.5 millimeters of facial axial reduction. In addition, they require 2 millimeters of occlusal reduction. So if this is how much tooth structure needs to be taken away, that's a substantial amount of tooth loss that occurs. If we're to do a layered zirconia restoration, it's really not that much different. We may save about 0.2 of a millimeter because we save opaquer. But outside of that, essentially a layered zirconia restoration needs the same amount of reduction to occur. And really today, they may be the most aggressive preparations. On the other hand, if we look at gold restorations were phenomenal because with gold, we were able to take away only about 0.5 millimeter to 1 millimeter axially and about 1 to 1.5 occlusally. The ideal material is really something that has a preparation parameter like that of gold, but at the same time has some natural characteristics so they look like teeth. Because patients today are much less likely to accept gold restorations in order to restore their mouth. Some do, and whenever they do, it's a great benefit. But many do not. Many want natural looking restorations. And to that end, we should consider some of the aesthetic alternatives that are available that can also be conservative. So the ideal restorative material is really something that's strong, conservative, and tooth colored. Now, Dr. Edelhoff and Sorensen in 2002 published this paper in the Journal of Periodontal and Restorative Dentistry. And in this paper, what they did is they examined how much coronal tooth structure is lost with various preparation designs. When we compare a porcelain fused to metal restoration, so full coverage porcelain fused to metal crown, to a partial coverage glass ceramic restoration, like that of the Empress Onlay, there is a drastic difference in how much tooth is lost. The Empress Onlay has about 39% of volumetric tooth loss that occurs. On the other hand, the porcelain fused to metal restoration has about 75.6% of volumetric tooth loss that occurs, and a full coverage Empress crown is not that much better. It's about 72.3%. So the point being here is, if we consider partial coverage restorations, we save a lot of tooth structure. This does not include the root form. This is simply coronal tooth volume. So how much coronal tooth volume is lost in traditional preparation, full coverage preparation design versus partial coverage. Now, if we look at the traditional recommended preparation parameters for EMAX, we see the recommendation is 1.5 to 2 millimeters of occlusal reduction, 1.5 millimeters axial reduction, and 1.0 in the gingival axial reduction standpoint. Now, for many years, this was the ad or the clinical protocol that was displayed for EMAX type restorations. And many practitioners prepare these teeth with great success. At the same time, many practitioners also prepared teeth with a lot less reduction. So they prepared teeth maybe in the millimeter range of occlusal reduction and maybe 1 millimeter to 0.8 axially. And those practitioners bonded their restorations and they found that they worked. And we saw many third-party studies come out showing that it worked. And that these things, that conserved preparation was very possible with the EMAX type material, lithium silicate or disilicate type material. Interestingly enough, Ivoclar this year released a new drawing. And in their new drawing, what they state is, essentially, if you're willing to bond your restorations, so if you're willing to use an adhesive cementation protocol where a bonding agent and a resin cement are used, you only have to reduce 1 millimeter occlusally. You only need to reduce 1 millimeter axially as well. On the other hand, if you want to use something like a self-adhesive resin cement, you do not want to use a bonding agent, you do not want to go through the full bonding protocol, you do need to take more tooth structure away. You need to remove about 1.5 millimeters occlusally and about 1.5 millimeters in the mid-axial and then 1 millimeter in the gingival third. These differences, there's no difference in the material. The actual ceramic is the same in both cases. The difference is cementation protocol. And what we learned from this is cementation protocol is hugely impactful on long-term restoration longevity as well as thickness of reduction, how much tooth needs to be removed. If we look at Lissy Press, or initial Lissy Press by GC, we can see very similar criteria standpoints. if you take a look at these scenarios, looking at the posterior crown on the far left-hand side of the screen, over to the onlay and the veneer on the far right-hand side of the screen, traditionally posterior crowns may have been conventionally cemented. In a conventional cementation standpoint, you need 1.5 occlusal, 1.5 midfacial, and 1 millimeter axial. On the other hand, if you look at more bonded restorations, so the inlay in this case is bonded as well as the onlay and the veneer that are depicted, we need much less. So if we're willing to bond, we may be able to get down to that 1 millimeter zone, and I'm very comfortable doing that today. Many times my laboratory is uncomfortable with the process, and I have to share this data with them saying, you have my word that I'm going to bond this restoration in place, and because I bonded it, I'm giving you less occlusal clearance. That is intentional. I don't want to take away any more tooth structure than I have to. Today, I also don't want to cover teeth axially unless I have to. So I don't do circumferential preparations unless it's a must statement. So we start to look at these standpoints in axial preparation. We have to ask ourselves, is the paradigm different today? Do we need to cover teeth axially, or can we just bond across the occlusal table without having to do more of a traditional preparation? So this is the interesting paper that came out in Dental Materials in June of 2010. And historically, I was always taught that to protect teeth, I had to cover them axially. So I prepared circumferential margins, went all the way around the tooth, took away buccal, lingual, mesial, distal enamel, and dentin, and surround this tooth to keep this tooth from flexing and keep it from breaking, because that's what I was always taught. What we see today, and what this paper is showing us, is that if we take teeth, we bond glass-based restorations across the occlusal surface with no axial preparation, and that's what the far left-hand side is depicting. In the middle of your screen, you can see there is an axial prep. We bond something with an axial prep. Both cases are bonded. We put pressure on each of those teeth until they break. We see that there's no difference. There's no difference between when these teeth break. They break at the same level. With bonded ceramics today, the entire occlusal table is bonded across of it, and it does not need traditional ferrule as we think about it. We do not need to surround the tooth as we once did. There's literature coming out in the endodontic world that says we should try to avoid the cervical 1/3 of enamel whenever we can. There's a very healthy band of enamel that protects teeth, and whenever we can, we try to keep margins coronal to that point. So today it's only caries or fractures or aesthetic reasons why I go cervically. If I can avoid those issues, I keep my preparations much higher and maybe only prep the occlusal table. In another study by Dr. Guess and colleagues, and this was done in December of 2013, what they did was they did 3 different onlay designs. The first was a palatal cusp covered only onlay. The second was the entire occlusal table. And the third was buccal or facial preparation in addition to an inlay and the palatal cusp. What they found in each of these scenarios, they took all these restorations, they prepared them occlusally with occlusal thickness of 0.5, 1.5, and 2 millimeters of occlusal thickness. They then bonded these restorations in place, and they pressed on the teeth until they broke. And what they found was there was really no difference. Even with thin restorations, when we bonded them in place, they were able to take very, very high occlusal loads. Historically, I would have thought the thicker the restoration, the more tooth coverage there is, the stronger the overall restoration would be, the stronger the tooth would be. And we find that that's not the case. Whenever we can preserve enamel, we must consider doing it. The more enamel we prepare and the more dentin we get into, the more dentin flexes. As dentin flexes, fractures can occur from the inside out. So from the dentinal interface out towards the ceramic. So general rule of thumb is, the deeper we get into dentin, the more we need to have in thickness in ceramic. The more we're in enamel, the lesser thickness in ceramic we need. And we find that we do these thin restorations, and they work time and time again, and we preserve a lot of tooth structure. Now the new age of zirconias, so if we transition here from preparation design to new age zirconias today are much less opaque than their sister products in the more traditional zirconias. They have this natural look that's there, but one thing to consider is, as we discussed before, in order to get this natural look, we have to increase this phase of cubic zirconia. Dr. John Burgess at the University of Alabama is one of the researchers I trust wholeheartedly. And in his lab, what they're starting to find is, if you're to air abrade translucent zirconia, you will cause microfractures. So when translucent zirconia is abraded, microfractures can occur. If microfractures occur, the ceramic is much more weakened. It does not have that toughening phase like traditional zirconias have. So it is imperative that if we use aesthetic zirconias today, or translucent zirconias, that we strongly consider using a resin-based cement. At the minimum, a self-adhesive resin should be used with these materials. In terms of preparation design, manufacturers today report that you can get down to about 0.8 millimeters in occlusal thickness. Now that number, I am concerned about it. While this is theoretically possible, my concern is when we go to try this restoration into the patient's mouth, if there's any occlusal adjustment that needs to be done to the restoration, we've now thinned below 0.8 of a millimeter. Once we drop below 0.8 of a millimeter in thickness with translucent materials, we start to lose their strength. In terms of traditional zirconias, once we drop below 0.5 millimeters or 0.5 millimeters, we lose our strength. So I don't like to operate in these ultra-thin worlds. I believe in conservation of tooth structure, but I also want to be cognizant that we don't want to push the envelope too much where fractures can occur. The most common area of fracture can be the central groove. In the central groove becomes an area that, as clinicians, we tend to get under-reduced. At the same time, we ask our laboratory for beautiful anatomy. So if we don't quite give them enough room, yet we ask for beautiful anatomy, the central groove can get quite thin. My recommendation would be for translucent zirconias, really consider at least a millimeter of occlusal thickness, maybe up to about 1.2 millimeters of occlusal thickness. And that's what I would really feel more comfortable doing with these translucent materials. Now with traditional high-strain zirconias, our occlusal preparation can be close to 0.7 to 1 millimeter. Again, 0.5 is a minimum thickness. I would recommend not getting that thin. Again, if you have to adjust, you may drastically weaken the overall strain. We need an actual reduction of 0.5 to 0.7. I'm comfortable with that with the traditional materials. We do need a more tapered preparation. That taper preparation should be on the order of 10 to 12 degrees. In a rounded shoulder margin or a chamfer margin is acceptable. The preparations must be rounded. Now at times I do consider partially veneering, although I'm doing less and less of it today. And part of the reason I do these partial veneered zirconia restorations is because this paper from 2011 by Marshaks of the USC, University of Southern California. And what they did in this paper is they discussed essentially a 3/4 zirconia crown. So the occlusal table, all functional surfaces, the palatal surface in this case is all zirconia, and the facial surface is layered with traditional veneering ceramic. What this does, it gives you the beauty of the ceramic, of the layered ceramic, yet gives you the strength of the zirconia. This is a possibility to use it. Now when I use it primarily for fixed partial dentures or bridges. That's when we use something like this. So in this case, I did a 4-unit span where I had a canine as an abutment as well as a first molar as an abutment, and we were replacing the 2 bicuspids. So in this case, we did zirconia across the entire occlusal table as well as palatal surface, and we veneered the facial standpoint. This is essentially where I use this type of design today as for posterior bridges. I'm not a big fan of using glass ceramic in spans over 3 units. I also don't like to go to a first molar. So personally, I use zirconia in the posterior for bridges as well as second molars. My bicuspid zone, anterior zone, I'm much more glass ceramic based or lithium silicate based today. Now, if we are to do a bridge, or a fixed dental prosthesis, what I would consider really looking at is the height of the connector. So in zirconia, it's very important that the height of the connector is at least 3 millimeters. there's kind of a general recommendation that's been made, and some of this data comes from Glidewell. One of the general recommendations is that if we get to 3 millimeters of connector height, that can ultimately lead to 27 cubic millimeters, and that's the magic number. So if you take the height of the connector and you square that, you get to 9. You then multiply by the width of the connector, or the buccal lingual dimension of the connector. So height squared multiplied by width, if that total equals 27, we tend to be safe. If that number drops below 27, we have a higher risk of fracture. So one thing to do before you take your impressions is to always visualize what your connector height may be. Look at your tissue profile and make sure there's not a plunging cusp opposing it. When I prepare ceramic restorations today, these are my go-to burrs today. I've essentially moved to kind of single-use burrs or single patient burrs today. In that world today, I tend to use a microcopy 1116.8 burr. That's equivalent to an 856 or rounded shoulder burr. The reason I use single patient burrs is because they have very precise cuts to start with. They're much more efficient. So I start with a coarse burr, so a rounded shoulder coarse burr, followed by a rounded shoulder fine diamond. And that is essentially the burr sequence I use on 100% of my posterior restorations today, the vast majority of my anterior restorations as well, for full coverage. If I'm doing veneer preps, I do use a few different burrs, but a rounded shoulder margin is what I want to create. So a burr that's like this is the goal, a rounded shoulder type diamond. Interesting enough, if I need to remove a zirconia preparation today, the way I remove it is not with a coarse burr. The data today shows us that we can use a fine diamond. A fine diamond actually has a lot of surface area and contact. It's much more efficient in cutting through zirconia, and these fine diamonds will easily get through the restorations. I don't use a specialized burr that may cost $10, $12. I use these single patient used diamonds at about $2, and they tend to work very well. Now, if we think about cementation, through this course of the presentation, we've discussed how important cementation is, but I haven't delved into specifics. And that's what we get to do now, is we get to look at the nuances of cementation. Now, the first thing we have to cement, for the most part, if we're not making restorations in our own office, is provisionals. The two provisional cements I tend to utilize for full coverage restorations are GC Temp Advantage, as well as Cling 2 is another nice cement. The reason I pick these cements and why we like GC Temp Advantage so much is there's a desensitizer built into it. In addition, it tends to stick to the restoration and not the preparation. So on the day of provisional removal or final cementation is going to be done, I don't have a lot of residual cement that's stuck on the tube. It cleans off very, very nicely. And the number of D-bonds that we get are few and far between in a given year. Restorations simply stay in place. So we tend to see that with both of these cements. Now, in terms of restorations, I want to look at bonding. So when it comes to bonding restorations, I essentially like to bond all of my composite restorations as well as all my glass-based ceramics. So I've mentioned the term glass-based ceramics a lot. What do I mean by that? A glass-based ceramic is anytime I have silica present. So that includes your feldspathic porcelains, your Empress restorations, your Emax restorations, your Lissy Press restorations, anything that's etchable. So anything that can be etched and be silinated has glass in it. I want to bond all those restorations. So at the minimum, I bond all my Empress, hybrid nanoceramics, feldspathics, and indirect composites, as well as all my partial coverage lithium disilicate or silica restorations. And if something is thin, if it's less than 1.5 millimeters, I bond it. I also bond my short wall zirconia restorations. When we think about resin bonding, we should think of the standpoint of there's two substrates. One substrate is the ceramic, the other substrate is the tooth. I still believe that whenever enamel is present, I'm going to etch it. So the more enamel quantity I have, I like to use a total etch technique. I might use a universal bonding agent, but I use a total etch technique. Whenever dentin is present, I use more of a selective etch technique. So I etch the enamel, but not the dentin. On the ceramic side, Whenever I have a glass-based ceramic, I use a hydrofluoric acid etch as well as silane. Whenever it's zirconia, hydrofluoric acid etch and silane do absolutely nothing, so they're not useful. How we use hydrofluoric acid etch is very, very important today, and it's very different than how it was used in the past. Historically, we would use a very strong concentration of hydrofluoric acid at about 9 to 10%, and we hydrofluorically acid etched for about a minute. And that's what we did with Empress type restorations. With lithium silicate and disilicate restorations, we want to etch at much lower concentrations. We want to etch with a 5% solution for 20 seconds, or a 4% solution for 25 seconds. We do not want to have the long etching times we had in the past. And as this image by Dr. Gary Alex shows, when we over-etch, we can actually get a salt formation that can weaken the ceramic and decrease bond strengths. Now, once the restoration is etched, and that normally happens in the laboratory, but if you're doing it in your own office, right, the next stage would be salination. So we get the restoration back from our ceramist that's pre-etched, or we etch it in our office. We then want to silanate. And when we silanate, we want to place the silane on for about 60 seconds. That allows the ceramic chemistry to respond to resin. It's essentially a coupling agent between ceramic and resin. Now, there's different types of silanes that are available. In some cases, we have pure silanes. So you have 2-part pure silanes like that of Bisco, which is bis-silane. We have ceramic primer 2 by GC, which is a pure silane. Or we have G multi-primer. And G multi-primer, GC's multi-primer, is actually silane as well as an MDP-based zirconia primer. So kind of two things in one. Regardless of which one you use, we want to make sure we silanate etched ceramics. And Monobond S is another one that is also a zirconia primer as well as a glass ceramic silane primer. When choosing a cement in terms of resin cement, one of the first things to consider is light accessibility. Do we have enough ability to transmit light? When restorations are less than 2 millimeters thick, I generally use a light cure cement. And when they're more than 2 millimeters thick, I use a dual cure resin cement. In terms of dual cure resins, there's many, many good dual cure resins on the market today. But one of the key factors I look at is compatibility. We need to make sure our dual cure resin cements are compatible with our adhesive of choice. If you've ever had a core buildup come out with your provisional, the reason that may have happened is because your dual cure core buildup was not compatible with your adhesive. So it's very, very important to look at the adhesive instructions and is your adhesive compatible. So what I generally like to do is stay within the family. If you stay within a family of materials, your chance of success is higher. All three of these materials are excellent, but the way they operate are different. So in terms of GSM Link Force, the product in the middle, that has both a dual cure additive that can come in addition to the adhesive that's there. So because as a dual cure activator, the dual cure activator allows the bonding to occur in a no light stage, so things become compatible. If you're in a canal space where you can't get light to it, etc. So we want to look at compatibility standpoints. Now, one of the reasons why I like GSM Link Force, a newer cement in the marketplace, is that it has this try-in gel. So it's a dual cure cement, yet it has a try-in gel. This particular material can be used for any glass-based ceramic restoration as well as any zirconia-based restoration. The universal primer that we discussed earlier has MDP in it, so it can be used on zirconia. It also has silane. The bonding agent is flexible. It is a universal bonding agent, so it can work in an etched method as well as a selective etch method or no etch method. There's flexibility that's there. It's highly filled, and it has very nice aesthetic properties to it. The try-in shade allows us to determine what shade of cement we want before we go to place, so we start to utilize that. And this is a cement I like to use in terms of posterior restorations. Now, with my veneers, I tend to use more of a non-light cured cement. So, with my veneers, I tend to use a light cured cement. I want to have more control over that matter. So, with veneer standpoints, I don't like to use dual cure. I like to opt for light cure. So, whether it's NX3 by Kerr, which is an excellent cement, or 3M's Reliax veneer, which is also a great cement, Those work very, very well, and I've used them with great success in the past. Something I use more on an off-label standpoint is actually one of my favorite flowable composites. So Geno Universal Flow is one of the flowable composites I use, and it really has a nice ability to stack when you want it to get flow across the surface. And what I do with that flowable composite is I actually use it almost on an off-label standpoint as a veneer cement at times. It stays in my restoration nicely, yet I can manipulate it into my restoration. So from a veneer standpoint, restoration is less than 2 millimeters in thickness. Light cure is what I opt for, either traditional veneer cement and or flowable composite. In terms of posterior restorations that tend to be more than 2 millimeters thick, I like to use dual cure cement. Now, self-adhesive cements and self-adhesive resin cements in particular have become kind of a workhorse in dentistry. They work very well for full coverage restorations. They are technically indicated for partial coverage. For the most part, I do not use them for partial coverage. I will use them for full coverage. So if I'm cementing a zirconia crown today, or maybe an Emax or lithium silica restoration with lithium that's thicker, I'm comfortable using these cements, but I do not use them for partial coverage. These cements have improved quite a bit over the years. If you take a look at this clinical slide, in this case, this lower right second bicuspid was a tall preparation. I had 1.5 millimeters in thickness. It was a strong glass-based restoration. We conventionally cemented this. So I used a self-adhesive resin cement, and that's what we utilized to cement this in place. And really had no issues with it because it was tall, naturally retentive, and plenty of thickness. Now there's other ways to cement things, especially with zirconia. When it comes to zirconia, things can be as simple or as complicated as you want to make them. With proper preparation form, you can literally use any cement that's out there, including zinc phosphate. So if you like to mix powder and liquid, you're welcome to use it. It will work with zirconia, as long as you have traditional retentive properties. However, there are always ways to improve things further. So with zirconia, we can treat the intaglio surface or underside of the surface, as well as the substrate. We can use a hybrid approach where you treat the restoration but not the tooth. Or we can do no treatment at all and just cement as usual. All those become possibilities, and this is simply based on retentive properties. So if something is naturally retentive, I offer a resin-modified glass ionomer. So something like Fujisem and or Rely Excluding Plus is, I think, a great cement of choice. You can also use a bioactive cement, like a ceramide type cement, will work well in this category. On the other hand, if I don't have proper retention, or I have maybe something less, I'll opt for a self-adhesive resin cement. So this 4-unit bridge case, I knew there was going to be a little higher load that's being placed here. Our canine preparation was a little bit shorter than I hoped for. So we used GSEM Link Ace in this case. It was easy to clean, went to place, light activated, or light accelerated I should say, and we're able to get this in place with really no issues. Now if I want to truly bond zirconia, I have to do something different. Zirconia has no glass in it. Because there's no glass in it, I have to treat the surface so that a resin cement will actually work. So in that case, what we need to do is consider the primers in the marketplace today. And all these primers do a good job. In G multi-primer as well as Monobond S, these two primers work on both glass-based restorations as well as zirconia-based restorations. So you can kind of have one bottle that does everything. If we do this, the glass as well as zirconia react so that resin can bond to it much, much tighter. It's a much better bond that occurs. So today, I air abrade my zirconia restoration, followed by priming, followed by resin cement when I want to have true bonding occur. Air abrasion is a key component to that. So relatively low pressure with relatively fine particles. Now you understand we've covered a lot of material in a relatively short time. And really, in summary, there's been many new advances in ceramic dentistry. And what we should really consider is more conservative preparation designs. With the beautiful materials we have today, the nice part is we can also be conservative. Now, we can be even more conservative if we choose to use proper cementation protocols. If we offer bonding today with the great resin cements that we have, we can be thinner in our preparation designs. and we can get potentially greater long-term success by preserving that tooth structure. Now, in parting, before we get to questions, what I want to do is I really want to thank you for your time today. Albert Einstein once said, once you stop learning, you start dying. And today I want to thank you for living with me in this journey, and hopefully you've been able to get some information through this process. With that, I'll entertain some questions. All right, so it doesn't look like we're having any questions come in, so I'll just discuss a couple factors. A question I get a lot is, how about the air abrasion principles today, and what should we do? One of the big concerns we have with zirconia in particular is that when we put it into the patient's mouth, it gets contaminated with phosphate groups that are in the mouth. So one way to deal with these phosphate groups is to actually use air abrasion post try-in. So we air abrade the surface. You can also use like an Ivoclean type product. And by doing that, we freshen up the surface that's present. Once the surface gets freshened up, then we can go through our normal priming stages and get to full resin bonding that's there. So a question just came in is, how do I place bonding agents on restorations, especially when there's a dual cure versus a light cure component? So in those scenarios, whenever the bonding agent can be cured, we choose to cure it. And what I mean by that is, the thinner the bonding agent is, the more likely I am to cure it, because we tend to get better bond strengths. On the other hand, if we use a thicker bonding agent, I do not like to cure that. So with thicker bonding agents, I actually cure through the restoration. That is very true of a light cured standpoint. In terms of dual cure resins can be finicky. There's compatibility issues that come in with dual cure resins. So in some cases, curing it is just fine. In other cases, it is not, and that is manufacturer dependent. So in some cases, in order to have a dual cure resin work, you must use a dual cure activator. In other cases, you can use a 2-bottle 6th generation self-adhesive, or sorry, 2-bottle 6th generation self-etch, and that would work just fine. But be very, very manufacturer specific in those cases. Another question I have is, do I recommend using pumice or some other agent to clean the prep surface at all in delivery phase? And I would say absolutely. Essentially, 100% of our preparations we clean with a pumice. So a slurry of pumice, a pure pumice, no prophy paste at all. We use a pure pumice agent that goes in there, we clean the debris off the tooth, and then we get to our final bonding. In more complicated anterior cases, especially when I'm looking for even tighter bonding, I may use a very fine particle air abrasion. So my default of choice is a pure pumice. At times use air abrasion. So nothing too complicated, pure pumice and air abrasion. You can also use a Conceptus type product where you can mix a slurry of chlorhexidine and pumice together, and that works well also. And I think we have one last question that we have time for. It says, based on my experience, is there essentially a need for etching zirconia? So I would say do not etch zirconia. We do not need to etch zirconia. Zirconia does not have any glass. Because it does not have glass, hydrofluoric acid etch will not do anything to zirconia. And phosphoric acid etch will actually contaminate the zirconia negatively. Phosphate will bond to that zirconia and you decrease your bond strengths. So with zirconia, we do not etch it in any way whatsoever. So it is purely air abraded, followed by priming, and maybe using a product like Ivoclean to take off any excess phosphate group. And with that, that's out of time. Thank you, everybody, for joining me today. I appreciate your time with me, and the best to you and your family.